So there are already plenty of people, so I think we should start. Welcome everybody to the ESRF ILL Colloquium. Before I start with today's topic, I give a few informations. First, in January 2021, we shall have a colloquium by Sakura Pascarelli from European XFEL in Hamburg, and she will give a colloquium on science at XFEL. The precise date will be announced later, so please check the ESRF website for this. Now, concerning today's event, a few technical informations. The talk is broadcasted via Zoom and YouTube and will remain available for replay on YouTube. For the discussion, there is a question and answer box in the bottom of your Zoom window, which you are invited to use to ask your questions. Please don't wait for the end of the talk to raise your questions. And you can use that box to upvote questions you find most important and you would like to be answered in priority. So now to the topic of today's colloquium. So as we all know, we are in the midst of a pandemic which has already killed more than 1 million people and disrupted lives of billions of people, and as well as the economies of many countries over several continents. And besides the battle in the hospitals against the disease and in the labs to create vaccine, there has been considerable importance to the work of epidemiologists to understand the dynamics of the pandemics. And this has proved very important to assist decision makers, both medical and political, to address this very serious problem. And that's why we are very happy to have our speaker, one of the best experts on the topic, Professor Neil Ferguson from Imperial College London. Let me briefly introduce Professor Ferguson to you. He studied physics in Oxford and got his PhD in theoretical physics from Oxford University in 1994. And after completion of his thesis, he started working on the modeling of infectious diseases, first at Oxford, and in 2000, after moving to Imperial College in London. In 2008, he founded the Medical Research Center for Global Infection Disease Analysis, which is the head of. Neil has worked also as an advisor for various organizations, such as the World Health Organization, the European Union, and the British and US governments, and is a member of the National Academy of Sciences in the US and a fellow of the Royal Medical Society in the UK. The title of Neil Ferguson's talk today is Transmission Dynamics and Control of COVID-19. What have we learned so far? We're looking forward to your talk, Neil. Thank you.
Thank you, Patrick, and I'll just share my slides. So it's a pleasure to be talking to everybody today. As I say, I'll talk about what we've learned since January of this year about the epidemiology of this virus and implications for control. But maybe I will start off by saying what I'm going to cover, namely challenges of doing science and scientific research in a pandemic, where we are in terms of what stage the pandemic has reached, the science which drove early policy and is still frankly driving policy today, talk a little bit about the second wave of transmission that most of Europe has been experiencing, and finish with some remarks about vaccination and real-time modelling and informing policy making in the next few months, some lessons learned. So I've worked on many infectious disease outbreaks in real time, including pandemic flu in 2009, SARS in 2003-04, Ebola, and there are some common challenges, but clearly the COVID-19 pandemic has, in terms of its global scale and impact, dwarfs all of those. But the kind of common themes of all those outbreaks are that surveillance data and knowledge, if it's a new virus, of what we're dealing with is initially extremely poor. And that leads to great scientific uncertainty early on, which only gradually reduces over time. But people still need to make decisions. And so one of the roles of epidemiologists, modelers like myself, is to try and use very limited amounts of data early on to inform decision-making in a timely fashion. And so the perfect certainly can be the enemy of the good there. We don't have the typical luxury of months, and if not years, to answer a scientific question. I mean, typically we're working on the time period of days. And that's one of the reasons why most governments, certainly the UK government, doesn't rely on any one single scientist or scientific group for that insight, but pools analyses from multiple groups. But we never have a coherent picture, and you can see that in some of the scientific discourse and certainly the public and political discourse around this pandemic. I'll return to that topic later. But I would say, I mean, it's important to look at all the data throughout and to try and avoid what's kind of called confirmation bias of starting out with a particular predefined viewpoint on something scientifically or indeed politically, and just looking for the cherry picking the evidence which supports that viewpoint. We've just on the picture there, I mean, the centre I had has now published something like 38 going on 40 preprints reports on our website, and I think we're up to 25 or so papers. Getting the peer-reviewed papers out takes longer. But in addition to that, we've produced a lot of planning tools for governments around the world, and I should say, and we are supporting at the moment governments not just in Europe and the United States, but many in low and middle income countries as well. So this is a few days old now, but we're up to just show, I mean, it truly is a global pandemic. This is showing mortality by country. Europe has been among the worst affected continents, certainly the worst affected continent by population size, closely followed by North America and Latin America. And we're up above 1.3 million deaths now, though that, as I'll talk about in a moment, is likely to be a significant underestimate of the global total of mortality thus far. If you group reported deaths by the income status of countries, you see this pattern, which is informative. First of all, the epidemic took off much faster in high-income countries, and that reflects their global connectivity and global airline network to China and Southeast Asia, where initial infections got exported from. And they also have the best surveillance systems and the oldest populations, and that partly reflects why mortality has been so much higher in high-income countries, despite the fact that upper middle-income countries have a larger population size. So interestingly, the world really locked down almost simultaneously over a kind of 2-week period in March, from about the 13th of March to the end of March. And in high-income countries, it was a lot more developed. The epidemic had progressed a lot further, which is why you see that very fast exponentially increasing curve of mortality. Deaths are lagged 3 weeks behind cases. That reflects epidemic growth in European countries before they locked down. But very little infection had got into most of the other countries in the world, and therefore the epidemic growth you see in later months there in May and June in, for instance, upper middle income countries and lower middle income countries is growth in the presence of a lot of interventions, often in the presence of lockdown. So they acted earlier in the stage of their epidemic, but lockdown was less effective in those countries, and I'll come on to why in a moment. And so they still saw epidemic growth, but at a much lower rate than they would have seen had they not taken interventions. And finally, low-income countries, that's much of sub-Saharan Africa, except for South Africa, and a few other countries elsewhere, apparently have very low mortality. You can barely see it on that plot. It's a dark green right at the bottom. That really reflects lack of testing capacity and lack of vital registration systems, so lack of recording of deaths. Just focusing a little bit more on vital registration systems and low-income countries overall. First of all, one reason low-income countries truly have had a lower impact of this pandemic is the demography of their populations. And the middle graph here shows, as a function of the kind of which income band the country comes into, GDP per capita band, shows that the poorest countries in the world have over half their populations under the age of 25, whilst the wealthiest countries have a much flatter age pyramid. And given COVID-19, principally severe disease and mortalities, it principally occurs in the eldest groups in society. That explains partly why the mortality impact in low-income countries has been comparatively less. That said, they also have much weaker health systems, so the people who have got severely ill in low-income countries have had much less access to oxygen or ventilation. The other important thing is under-ascertainment of cases. So you could call underreporting. Under-ascertainment is a more neutral term, because a lot of that under-ascertainment is not deliberate. It reflects very limited access to testing, molecular testing capability, and also limited just overall ability of countries to monitor deaths in their population. So we've been doing, and the graph you see on the right here is from this report from a preprint. We worked with doctors in Damascus, Syria, to try and estimate for that country, which of course has been ripped apart by war in the last decade or more, the level of reporting of COVID mortality they were seeing. And so they reported only a handful of test positive COVID deaths, but there's this tradition of posting death certificates on Facebook in Syria so that families become aware of who has died. And there was an enormous uptick in the posting of such death certificates in summer months of this year, and also some release of excess mortality statistics. And that allowed us to estimate that really somewhere between only about 1 to 3% of COVID-related mortality has been reported in Syria. They basically had an enormous epidemic, but very little testing went on. And even in countries with much better surveillance systems, such as Mexico and South Africa, where they really have tried to test people, still, if you compare test positive COVID mortality with what has now been ascertained in terms of what's called excess mortality, so the extra mortality seen this year compared with an average year, then excess mortality is more than double reported COVID deaths. Low and middle income countries have also, as was indicated in my first kind of epidemic curve plot, much less capability to sustain responses. And so whilst all countries in the world nearly adopted close to lockdown measures, they weren't as effective in those countries largely. People have to go out to work and to get food almost every day, less in the way of a kind of social security system, and less ability of those economies to really support people in this sort of crisis. So the effect was less. They also have weaker health systems. The graph on the right here shows the availability of hospital beds per thousand population by different income strata. And low and middle income countries, particularly low and middle income countries, have way fewer hospital beds than high income countries. And so whilst lockdown was effective in high income countries and much less effective in middle income countries, I mean, all countries had to relax. The graph at the bottom there shows you one of the worst affected countries in the world, which did do a lot of testing, but in terms of excess deaths reported, Peru has reported 35,000 deaths, which is over 1 in 1,000 of the population dying, despite having put in place really quite a stringent lockdown. I'll step back a little now and talk about, well, how did we end up locking down, and what were the drivers of that scientifically and in public health terms? I mean, And so there are four key aspects which don't really require complicated modeling to justify the decision for lockdown. I mean, it's just understanding the epidemiology of this virus. So the first one is transmissibility, represented by what's called the basic reproduction number, the number of secondary cases each case generates on average in the epidemic. And we knew really from the early Chinese data, we thought that was in the range of the order of 2 to 3, let's say, average of about 2.5, 2.6. European data suggests a value more like 2.5 to 3. There may have been even some evolution of the virus to explain that. What that really translates into, though, given other characteristics of the virus, is epidemics which in the absence of control measures double every 3 to 4 days in size. And that is a rate of growth comparable with influenza pandemics. We knew the transmission route of the virus, that it was readily transmitted through respiratory route, and that has implications for the feasibility of implementing certain types of control measures. Perhaps the biggest contribution my group made, and one of the more difficult things to do early on with the very limited data we had available, was estimating the lethality of the virus. And the reason it's difficult is that typically, surveillance systems early in epidemics are very biased towards picking up severe cases, people with severe illness. We have much less knowledge of how many people are actually being infected, maybe with mild or no symptoms. And we used a variety of data sources to try and get at that in that Verity et al. Lancet ID paper published in, I think, May this year. But we put out a preprint basically, some months before that. We estimated that in China, the infection fatality ratio, the proportion of those infected who were dying, was about 0.6%, with considerable uncertainty, twofold uncertainty each way around that number. But that would translate into something like a 1% infection fatality ratio in European countries, given the older populations in our countries. And I'll come to how accurate we were in that early assessment in another slide, but basically the evidence supporting those sort of estimates has strengthened over time. And finally, we knew this was a novel virus, and therefore a priori we wouldn't have expected the human population to show very much in the way of pre-existing immunity to it, and therefore if everybody is potentially at risk, you can face having very large epidemics with 60–80% of the population infected before you gain herd immunity. And so the conclusion of just those simple statistics is that you have an epidemic which will overwhelm any health system of any country in the world. I should say there's an additional number, about 2 to 3% of people infected require hospital treatment. And I suppose the final piece of information we had by February, or late February at least, was that China had sort of led the way in imposing measures which I think even a year ago I would have thought I would never have expected to see implemented across the world. They had locked down Wuhan, indeed locked down the whole country, and that had been successful. So we had some indication that those measures could potentially work even in a modern society. We had historical information that from 1918 flu pandemic that such measures might have an effect, but there was more immediate data available from China. And then, my group and other groups, I show the London School of Hygiene and Tropical Medicines model, which was published later, are really about the same time, that's in late February to early March, put those numbers into mathematical models to actually generate estimates of trajectories of possible trajectories of the epidemic in high-income countries. And indeed, we extended that to model the pandemic in every country of the world and potential health impacts under different policy options. But really, the modeling was slightly secondary to the kind of fundamental epidemiological analysis behind it. Since then, we've constantly revisited the estimates which went into that early modeling and the early conclusions. First of all, in recent work now put out as a preprint and submitted for publication, we've reviewed the data on infection fatality ratio, and there are a couple of other very nice papers. There's a paper by O'Driscoll et al. In Nature published very recently, and a nice preprint by Levin et al. I've got on the screen there. They all come to very similar conclusions. And take similar methods. So we have two sources of data now. We have mortality data from many countries of the world, and we have data from serological surveys where people, after the first wave of the pandemic, a random set of the subset of the population was sampled, blood was taken, and tests used to see if they had antibodies against SARS-CoV-2. So adjusting for the sensitivity and specificity of those assays and then comparing overall infection rates in the population with mortality, you can get a much better estimate of the infection fatality ratio and stratify that estimate by age, which is what you see here. And you see a log linear relationship of the IFR with age, which means basically the risk of death if you're infected increases exponentially with your age, to really quite high levels in the oldest age groups, of the order of if you're 90 years old, of a 15 to 20% risk of death, but dropping to something more like a 1%, a 1% risk of death at around the age of 65 or so. The other assumption we made in early work was the entire population was susceptible to this new virus, which is generally the case for novel viruses jumping from animal species into humans. Because, I mean, if that assumption is true, then it implies that the epidemic would only, in the absence of control measures, the epidemic would only really slow down once about 2/3 of the population was infected, given how transmissible it was. And a completely unmitigated epidemic might even infect 80% of the population. So, to what extent can we assess now how accurate those estimates were? Well, a very nice paper in Science showed that, just published in the last few weeks, said that it looked for cross-reactive antibodies in different age groups in the random subset of population sample. And it very interestingly found that in the younger age group, 6 to 16-year-olds, there was evidence of about 60% of them having cross-reactive antibodies, but very limited evidence in older age groups. And that might explain, for instance, why younger age groups children have played less of a role in transmission of this virus than we might have a priori expected. And then there have been a variety of studies which have detected some level, not as high as that, but some level of cross-reactive T-cell recognition in the population at large. And then we can go from the other side and say, well, how big have some epidemics of this virus got in certain populations? Well, given most of the world has locked down and tried to control spread, there are not many examples of effectively an epidemic running completely out of control, where we also have serology data. But one of them is the area of Manaus in Amazonian Brazil, where we both have mortality data shown in the grey curve at the bottom there, and we have serological survey data. And if you correct that serological survey data for the sensitivity, which wasn't perfect, of the assay, and the fact that antibodies decay and therefore people go from seropositive to seronegative, then we estimate that basically 2/3 of the population of that area got infected. And that was an area which really didn't put in place many of controls. They literally had bodies stacked in the streets at one point. And that's really very comparable, that level of infection in the population, with what we predicted early on. So, what's the significance of the cross-reactive immunity? I think most immunologists, and certainly I believe, is that it probably doesn't stop you getting infected overall, but it may well have the impact of modifying disease, and so may well explain why children, young adults have many fewer symptoms and much less likely to get severely infected than the elderly, for instance. Of course, across the Northern Hemisphere in the last few months, we've seen a resurgence of transmission of this virus, and the situation in the United States is particularly worrying at the current time, with over 2,000 now deaths a day again. And in the next week or so, they will exceed their previous peak in daily mortality. The growth, though, is slower than we saw in March, And that's because no country has completely lifted all control measures. Case numbers, of course, are much higher than in spring wave, and that just reflects the fact that every country has scaled up its testing capability. Back in September, October, very skeptical groups were saying, well, this is just a case-demic, as they called it. We just saw a massive increase in cases, but at that time, no increase in hospitalizations or mortality. That is no longer the case now. I mean, we knew hospitalizations, mortality, deaths lag case detection by several weeks. But across Europe, we've now seen the same exponential growth in hospitalizations, deaths, and case numbers. And in some local areas of a number of countries, France included, certainly the UK and Northern England, we've seen healthcare demand approaching surge limits in some local areas. And that really has been, above anything else, been the thing which has forced governments to act. The positive thing, if you look at both hospitalization and data on hospitalization, data on mortality, and data on infection rates, is we've got, across the board, we've got much better at treating COVID cases in hospitals. So the mortality rate in hospitals is probably about halved since the spring wave. And really this could have, I mean, we did anticipate the situation we would end up in autumn. We anticipated it back in February, the early modelling I undertook, that lockdown is basically a holding action. It only works whilst it's in place. And whilst lockdown and suppression, as we called it, so using social distancing to drive down transmission, so the reproduction number is below 1, I mean, it worked as intended, but it only works whilst it's in place. And just if you lift the measures, then inevitably, as you relax more and more and allow more and more social contacts in society, the reproduction number will go above 1 at some point. There was, of course, a hope in the summer, spring, summer, that maybe we could avoid lockdown again, that by ramping up test and trace capabilities, early cluster detection, using local measures to lock down isolating contacts of cases, we could keep a lid on transmission, the so-called test and trace paradigm. And in some countries, Germany notably, I mean, that has been quite successful, but it can only cope with a certain level of transmission. And with the level of relaxation of social distancing we saw, that threshold level was exceeded, and across the continent, test and trace systems have been overwhelmed. And that leaves you coming back to social distancing as the principal means of control. I said before, I mean, we anticipated this really back in February. This is quotes, I won't read them out, but quotes from our famous Report 9, which really just summarized, wasn't novel at the time in terms of, there was nothing in it which governments, I mean, either the French government or the UK government or the US government hadn't seen already, but it was intended to put that modelling in the public domain. But we said at the time that it wasn't at all clear that suppression would succeed long term. I mean, given the economic costs and how disruptive the measure would be, there would be inevitable demands to release measures, and that transmission would resurge once lockdown was released. So we have this fundamental policy challenge. That's the hospitalization, daily admissions to hospital in the UK, showing the first and second wave there. And you see the now infection levels in the UK are at about 60% of what they were at the peak in March, but the curve is much flatter. So there's a real risk, unless we can keep infection levels going down. I'll talk about the kind of new second lockdown in a moment. Then we could well see the same sort of mortality in the second wave until we can roll out vaccine, as we saw in the first wave, which I mean the US is seeing today. So I mean, lockdown delayed spread but didn't stop it, and we still have a risk for the next few months that if we relax measures too much, health systems will be overwhelmed, just as they nearly were in March. What we have, though, is a situation that where in March, everybody in the population could see the potential risk COVID was posing, but nobody had experienced lockdown and seen the economic impact and the harms caused by the control measures. Now everybody has experienced what lockdown is like and seen the massive shock hit on the economy, and understandably are very reluctant to go back into those sort of measures again. And the political consensus is therefore fragmenting, both among politicians and in the population at large. And so what we've seen across Europe is governments reluctantly ramping up measures in the face of basically increases in hospitalizations and deaths. Scientists just telling them this was going to be the consequence if you don't do anything else was not sufficient in most countries. They actually, in order to sell measures to the population, they actually needed to see hospitalization and deaths unfortunately rise to the levels they now are. And the challenge epidemiologically and in terms of advising on policy is that whilst we can summarize our understanding of transmission, things like the reproduction number, quite well, it is and we have better understanding of where transmission is happening, the level of that understanding is not such that we can a priori predict the impact of, for instance, what will be the effect of closing bars. What across Europe we're seeing is governments using different suites of interventions in different countries and basically adjusting them until they get to a set of measures which is able to achieve some degree of control. We do have a lot more data though than we used to have, and I'll talk a little bit now more about the kind of science of what we're doing. So the UK, having started with very little testing, now is probably doing more testing than any European country. And we have data at a very fine spatial scale, publicly available data on patterns of transmission. This is from a few weeks ago now, and so the pink areas of this map, and this is an analytical tool which is publicly available, we produce, which what it does is basically track the epidemic and do short-term forecasting. The pink areas were areas where case numbers were increasing at the time, green where they were decreasing, and the green areas were the few areas with intensive control measures in place at the time. The value of having those local estimates of things like the reproduction number is we can correlate patterns in the epidemic with the interventions being put in place. First of all, I mean, behind each of those areas, we produce a dashboard which tracks in a particular, this is Bolton, a town in the north of England, patterns of transmission over time, estimates the reproduction number, and then forecasts forward. But we have been, before the UK locked down, as I said, like many other countries, I mean, it had introduced this system whereby, depending on the incidence, number of cases per week, in different areas, controls were ramped up or ramped down. And we have these, therefore, local tiers of it, and they were called tiers of interventions. Tier 1 being the most open in terms of society, and Tier 3 being the most restrictive. One of the things we need a much better handle on is what the effectiveness of different interventions are. And this is what the kind of wealth of data we now have available gives us. So we can actually then fit basically quite simple regression models to data from different local authority areas week by week, looking at the correlation between the reproduction number, which is a measure of the intensity of transmission, and the controls in place. And this is what you see on this plot here, namely the the fit of the model to the reproduction number we observed in different areas in different weeks. And then the colored points represent which tiers those local areas were in at the particular time. And you can see a clear effect size of, if you're on a higher tier, then transmission is lower, transmission intensity is lower than if you're in a lower tier. You can then ask the question, well, if we just, and this is exactly what the UK government did, well, this is the data they used. So if we just carry on the way we're doing before we locked down again and just move areas up through the tiers, would we achieve control of the second wave? And the answer was, well, we would achieve it in some areas, but not in others. And we estimated somewhere, or slightly out of date estimates, that we'd have achieved a control in about 3/4 of areas with Tier 3 restrictions, but not all. This shows other data. This is now not just data produced by my own group, but it's what's called consensus estimates from the SPI-M committee in the UK. Unfortunate acronym, but it's basically one of the groups advising our scientific advisory group for emergencies. And it shows, first of all, hospitalizations per day up to 4 different time points. This is where 4 different times we were projecting forward. And what you see is ensemble projections here, bringing together multiple models. And the red points are the points which were fitted to at each time, and then the black points are what actually happened in the epidemic and as compared with the projected growth. And I mean, this is not an overwhelmingly difficult feat of projection, given if you're seeing close to exponential growth, you can kind of extrapolate quite easily, but it's the pattern of exponential growth and the levels we were projecting hospitalizations would reach by this month or into early December, namely of over 2,000 to 3,000 hospitalizations per day, which would overwhelm healthcare resources in many areas of the country, which led to the decision to lock down. The other problem with just local area measures, which are triggered really by healthcare demand, for instance, or incidence, is that the net effect of that sort of intervention is just to bring all areas up to a high level of transmission, which leads you to a kind of scenario between now and March of basically not exponentially growing transmission, but intense transmission across the continent through until we have vaccine. So the benefit of these second lockdowns, which aren't really lockdown lights, they're not as intensive as what we put in place in March, is that we bring down transmission everywhere for a fixed period of time, reduce healthcare demand, reduce mortality, and then at that point try to stabilize it and keep infection levels flat until we can actually roll out vaccine in a month or two's time. We have been looking more formally at that kind of the classic trade-off which has been played out in the control of this pandemic from really April, May onwards, which is the trading off of the health benefits of interventions and health costs of not intervening against the economic damage caused by social distancing measures. And so I don't have time to go into details, but I mean, we have a preprint available on the link there. You can formally, integrate economics into models. I mean, what we've done is stratify a traditional epidemic model into industry sectors. So people work in different industry sectors. I mean, there's some 60 of them. One of the key pieces of information then is asking the question, can you attribute a certain risk of transmission to each sector? And there is some data on that, on contact rates, associated, interpersonal contact rates associated with different economic sectors. And then you can build a model which both tries to, jointly optimize epidemic control and economic output, and basically says, this notion of a so-called contact budget we can have, and the level of contacts in society, and still maintain control over the virus. And what's the optimal allocation of that budget by industry sector, given that we want to keep schools open as well, which achieves control of the virus. The other modelling we're doing, I'm using similar modelling approaches, is we do a lot of real-time modelling for the UK government, one of several groups doing it. And there it's critically important to capture healthcare demand. And so this shows you how our model, I'm not going to go through every box here, but the complexity of modelling, given this virus has a wide variety of levels of severity, and then there are complex set of pathways people can take through hospitals. In order to kind of fit these models to healthcare data and to project forward healthcare demand, you need quite a complicated representation of that clinical care pathway in the model. We're fortunate in the UK, we have an enormous amount of surveillance data, as well as just cases and hospital admissions and bed occupancy and deaths. We also have weekly serology data being collected on antibody levels in the population, and random infection prevalence surveys, where a random set of, I think it's nearly 100,000 people a week, are being swabbed for the virus, and that gives you a measure of levels of infection in the community, a lot of which may not even involve symptomatic disease. And then so we fit these transmission models to these data streams and then estimate things like the reproduction number of the virus locally and nationally every week for the SAGE committee, generate short and medium term projections, and then use modeling to evaluate policy options. So this kind of shows an indication of the sort of data streams we're fitting to. At the top there is fitting regionally in England to serology data. Bear in mind the serology, so the model fit doesn't allow for the, model estimates in of the lines with shaded areas around them representing uncertainty. That shows infection levels in the population. There is evidence, certainly in some areas like London, of declining seroprevalence, which is probably indicative of waning of antibodies. And then at the bottom, you show I'm showing our fits to mortality, not just hospital deaths, but we fit separately. Same model represents care homes, deliberately represents care homes because care homes accounted for nearly 40% of mortality in many European countries. And there are particular challenges with controlling infection in care homes. So the sort of things we've been looking at in recent weeks for SAGE and SPI-M have been, first of all, what do we do at Christmas? The UK government, there's a lot of political demand to relax measures over Christmas. What might be the potential impact of that? And also what's going to be the impact of the current lockdown the UK is, England is in and will be in for another week. And so the different coloured curve, first of all, you see the fit to data in the past there at an England level, but the different coloured curves represent potentially different levels of impact of the lockdown. It's difficult to predict a priori. And then the top two plots represent if we continue with not the lockdown, but continue with some level of control measures over Christmas. And then at the bottom, if we relax interventions, relax social distancing for a week over Christmas. And of course, the ones at the bottom are more pessimistic than the ones at the top. If you relax social distancing, even for a short period of time, you end up with more cases. And then comparing the right column with the left column is what would be the impact of then potentially locking down or at least tightening up social distancing measures in January compared with just letting things progress. Now, I should say, since we generated these plots, policy, these were generated 2 or 3 weeks ago, policy has evolved in the UK. And so the UK is now, or England, I should say, be careful. England has now decided to go back into a tier system after lockdown, but an intensified tier system compared with what was in place before, more intensive control. So hopefully, when this lockdown finishes, we won't necessarily see the same level of resurgence of transmission as is plotted on these curves. We will see maybe a rebound in some areas to some degree, but if it's going to be, if it increases, it will be to a limited extent, and maybe we'll even keep infection levels flat. That just shows hospitalizations rather than deaths. We've also been doing a lot more detailed work on analysing data from particular epidemiological studies, and these graphs are from a paper we were involved in published in Nature, studying transmission in the Italian town of Vo, where early in the epidemic, where they did very detailed studies in 3 different time periods. And that sort of detailed epidemiological data tells you important things about, for instance, what types of contacts are most responsible for transmission. We know now that clearly that contacts within the household, as it was always expected, are particularly important, but other indoor contexts where there's extended interaction between a small number of people pose particular risks. We can look at questions like how common is asymptomatic infection and how important is it for transmission? How heterogeneous is infection, the idea of super spreading? We now know that probably something like 10% of people infected account for 90% of cases. Or maybe a little less in the household context, but certainly in the kind of in the wider community context, that is true. Trying to understand what measures are needed in terms of physical distancing in terms of airflow and other forms of risk mitigation to make particular venues less likely to allow them or permit transmission of the virus, so-called COVID secure venues. We've done quite a lot of work in recent months also anticipating the availability of vaccine, and this is work for the World Health Organization, and we're also to some extent feeding into UK government policy making on this. I mean, as we know, and this is, again, I should have updated the slide, we now have results from 3 vaccines, but we have multiple vaccines under development, and at least the first 2 vaccines, which reported both mRNA vaccines, showed very promising high levels of efficacy. I mean, the AstraZeneca Oxford vaccine rather lower and there are more question marks about it, but still significant efficacy. But what we don't know as yet is how that efficacy varies by type of protection. Does it protect against infection and therefore reduce transmission, or does it just protect against having symptoms, disease, or maybe even severe symptoms? What's the duration of protection for the 2 mRNA vaccines? There was a very short period of time between when people got the second dose and when they got infected, and therefore when the trial ended. And so we're really probably seeing the maximum efficacy of those vaccines. When antibody levels are very high, it's not clear whether that will decay over time. And one of the explanations for the Oxford vaccine having a lower efficacy is there was a much longer delay between vaccination and when people got infected, because for the UK trial, most people were vaccinated in April, May, where there was not much transmission going on, and then only have been infected in the last few months in the second wave. We don't know how efficacy will vary by age, particularly in the most vulnerable, frail elderly groups. So until we see this data, it is difficult to make definitive predictions. Nevertheless, and we've used very similar model formulations to look at, for a range of scenarios about the properties of the vaccine and how it behaves, about what are optimal allocation strategies, both globally, which I won't talk about, but also by age. So first of all, the top 2 plots here really address the question of how much of the population needs to be vaccinated in order to control this pandemic, to stop transmission. This is under the assumption that vaccines are going to, well, on the left-hand side, vaccines do actually prevent transmission, prevent people being infectious. And I mean, you see a classic trade-off, which is a bit well known from very simple models of the relationship between efficacy and coverage, that if you have a high efficacy vaccine for a reproduction number of 2, you need to vaccinate half the population, but if the efficacy is lower, you need to vaccinate proportionately more, and you need higher and higher coverage as the reproduction number of the virus goes up. The right-hand top plot shows the difference between a vaccine in the dashed lines, which only protects against symptom, but not against transmission or infectiousness, and one which prevents infection and therefore reduces transmission. Clearly, if you can reduce transmission with a vaccine, then you can have a much bigger impact. You don't, because of herd immunity, I mean, and the nonlinear dynamics of epidemics, you don't need to vaccinate the whole population in order to stop transmission. With a high efficacy vaccine, and given what we know about the transmissibility of this virus, we might only need to vaccinate 70% of the population to really stop the pandemic. And the last plot there shows kind of what's the optimal age groups to initially target for vaccination if you have a limited supply. So going across the x-axis is, imagine you suddenly have the supply sufficient to vaccinate a certain proportion of the population, between 0 and 80%, and then given if you have that much vaccine available, what are the optimal age groups to target? And clearly for limited supplies of vaccine, which is the situation most European countries are in at the moment, it's optimal to target and protect those people most at risk of disease, the frail and the elderly. But once you get beyond a certain point, it can actually be better to target the people most likely to transmit, which is certainly older children, teenagers, and young adults. And then, of course, if you have a lot of vaccine, you should target everyone. And so we potentially have in this situation, particularly if it turns out that some of these vaccines have lower efficacy in the oldest age and age groups and the most frail and elderly, we have a trade-off between directly protecting people who get vaccinated and preventing them getting severe disease, or using vaccines to reduce transmission. That's basically all I had to say. I'll just finish with a few lessons. I mean, I've been heavily involved in both the science and some of the politics around this pandemic. Some lessons on both sides. I mean, first of all, why was Europe so badly affected compared with other continents? And fundamentally, it came down to testing and testing priorities. That, first of all, we had inadequate amounts of test capacity available in most European countries. There are some notable exceptions like Germany in February and March. But we also misdirected that test capacity, and we focused it on travellers coming from China. In some vein, and I had always said in policy meetings, it was a vain hope of stopping infection coming into the continent. What we should have done was set up sentinel surveillance from an early, and actually looked for evidence of infection in the community at large, and really at that time given capacity in patients coming into hospitals. Had we done that back in late January, then across Europe, then we would have had much better indication of how much infection was in the continent. And I think across Europe, not every country, but certainly the UK would have done, France, Spain, Italy, the worst affected countries in Europe, would have locked down much earlier had we had that information available. What we've seen, the thing which really explains the differences in the experience of this pandemic across Europe, are how far the epidemic had spread by the time the countries locked down. As I said, most countries locked down in the same week across the continent. The countries which had much lower mortality are the ones where the epidemic had spread less by that point than the ones which had higher mortality. So the most globally connected countries, again, the UK is the most globally connected country in Europe, but the UK, France, Spain, Italy, the biggest countries, and Germany, though Germany responded earlier, had better testing, but certainly the first four of those, the worst affected. So it's this combination of not just when you respond, but when you respond relative to the stage of the epidemic in your country, which has determined the mortality impact of this epidemic. And the fact that we were basically blind in early March to the true extent of spread explains a lot of what was seen after. I think we've learned that contact tracing can only ever have a quite limited effectiveness for this virus for kind of fundamental biological and epidemiological reasons. A lot of the transmission occurs before people have symptoms, and it's very difficult to scale up to very high volumes. It does have an effect. It shouldn't be dismissed, but it's not sufficient to really control this virus overall once you have high levels of transmission, as all European countries have had. In other contexts where there's lower transmission, Korea, Taiwan, New Zealand, it can do a lot more because you can dedicate enormously more effort for every case you find to really make contact tracing incredibly thorough. I think I've shown that, I mean, from an epidemiological perspective, I mean, the second wave was entirely predictable and was predicted. I mean, we anticipated it back in February. Whether it was avoidable is another question. I mean, I think that's a political, social science question, given how much pressure there was to reopen societies. It's almost inevitable that the relaxation of measures was going to continue until we saw transmission resurge. And I think the final and rather more disappointing lesson I've learned this year is that science, inevitably in a crisis of this scale, science is going to end up being politicized. And we have seen, unfortunately, quite a lot of people with particular political viewpoints cherry-picking science, the science which supports that political viewpoint, and then outright, disinformation and conspiracy theories out there, plus a lot of personal attacks on prominent scientists. That said, I strongly believe scientists should avoid becoming politicians themselves, regardless of what their view is. Governments are making decisions, are elected by us to make decisions on behalf of everyone, and are weighing up more than just epidemiology in making those decisions. And I don't think I have any more right to determine what policy should be than anyone else. What I can do is say, well, advise politicians, if you do this, then this is likely to happen. And if you do that, that is likely to happen. Give the most information that we can to, and this is true of all scientists, most information we can to inform policy making, but politicians are the ones who have to decide. So overall, I mean, I think this pandemic, I mean, just ending on a slightly optimistic note, I mean, we've seen over 1 million deaths, probably well over 2 million in reality. But we would have seen far, far more had the world not responded the way it has done. And so despite the enormous economic costs, that has brought the saving of many, many lives, particularly in the continent of Europe, where we have one of the oldest populations in the world. Even now, after the second wave, though, most of Europe has seen less than 20% of its population infected. And so if in the absence of vaccine, this pandemic is still at quite an early stage, given that we would need at least 60% probably to be infected to get herd immunity. And so until we have vaccine available and rolled out in the population, we're still going to be in this balancing act of trying to maintain control of the spread whilst allowing as much economic activity to continue as possible. And this is in a context where we are all tired, frankly. I mean, I'm certainly tired, but the population at large is tired, and lots of people in our populations have been catastrophically affected, not just by the virus, but by the economic consequences of the control measures imposed. We do understand transmission better, and we are learning all the time, and so we're getting a little bit better at doing that balancing act of not over-responding, as we arguably did in the first lockdown, in terms of it was very effective, but we basically shut down society completely. What we're seeing now are more nuanced measures which shut down certain sectors of the economy and prevent certain types of activity, particularly in the UK, kind of people visiting each other's homes, but allow other aspects of society to continue. Another positive thing has been the truly remarkable scientific progress made in just such a short time, and the level of open sharing of data and results well before getting into official peer-reviewed journals. And so the global scientific community has really pulled together in this, far more so than I would say the global political community. And I think we can now be more hopeful that vaccine will give a more permanent way out of current restrictions. It will take time, and it will likely be late spring before we can really see significant relaxation of the current measures in place. But I mean, we at least see the light at the end of the tunnel now. Thank you. Any questions? Is my chair going to? I'll see if I can see a question. Do you want me to just work my way through? I see.
I think I will ask the first questions until Patrick is live again. So
thank you very much, Neil, for this very active presentation.
Shall I just, I'll go through some of the questions.
Yes, please.
So starting at the top.
One
of the measures.
Trouble with the...
Yes, it's fine. I can do it. Masks. So funnily enough, I'm senior author on one of the very, very few peer-reviewed random controlled trials of masks to prevent community infection. This was with flu, with a woman called Raina McIntyre, who's based in Australia. And it's very difficult to do studies of masks at community level. So there is a paucity of data. That trial, I mean, it turned out to be underpowered. And so we had a hint from the trial of a reduction in transmission for people who adhered to mask wearing, which is one of the main problems, but it wasn't an overwhelming hint. So, I mean, what's my view on masks? I think they probably have a bigger effect at preventing somebody who is infected but hasn't recognized the fact they're infected from infecting other people than they do at reducing your own risk of it being infected. So they're better at reducing transmission from someone than stopping someone wearing a mask being infected. I think they probably have an effect, and there's more, let's say, circumstantial or observational data being gathered which suggests that, but it's probably not an overwhelming effect. Somewhere between 10 and 40% reduction in risk of transmission if you're infected and you wear a mask, and it's hard to be more precise than that. I'm going in a slightly random order. Did I analyze the effect of the cycle, 4 days at work followed by 10 days of lockdown? So yes, we've looked at a variety of periodic measures. I think one of the challenges with very short cycle times is the latent period of the virus and the duration of infectiousness. And so it is better if you imagine somebody who's infected during a work period, it is better to have a duration of them being at home which takes them out of being infectious before you open than a very short duration of lockdown. I mean, even so, I mean, short duration, it does come down to contact rates at the end of the day. So even very frequent on-off cycles are going to reduce overall transmission, but you get a slightly better effect and a clearer cut effect. And I think the messaging is easier around contact rates if the gaps are longer.
Sorry, my connection was down, so I could not comment rapidly. I would have a question. How do we understand that countries like Japan and Korea, which have an age structure similar to European countries, and also a level of development, access to healthcare very similar, why were they much less affected than European countries? Do we understand this, or?
So I would say not fully, but the likely hypothesis is they responded. So they were among some of the first countries to see cases, and they responded with very intensive measures at borders. I mean, basically shutting their borders to travelers from much of the world. And then very intensive contact tracing around cases and infections detected within their countries. So Korea and Japan, but certainly Korea, has driven case numbers down to very, very low levels. And once you're down at only having a handful of cases a day, it's much easier to dedicate very large public health resources to tracking individual chains of transmission and keep yourself there than it is in any European. I mean, by mid-March in Europe, I mean, both France and the UK had hundreds of thousands of people infected. So we were never, even if we'd locked down for the whole rest of the year, we would never have got infection levels down to what they were kept at in Korea. Korea also has mandatory quarantine in quarantine facilities for 2 weeks for all travelers coming into the country, with people only being released from quarantine after multiple rounds of testing. I mean, so they've adopted, I mean, similarly with New Zealand as well, they adopt very, very strict measures at borders. I mean, none of that, it would have been feasible in Europe had we adopted it in January, which is when we started to see significant numbers of cases coming in, or if we picked up transmission early in our countries, then closed our borders and then adopted a Korea-like measure. But because we didn't implement the community testing in the way that both Japan and Korea did early enough, we let our epidemics get so much larger that the sort of measures those countries are adopting are not practical in most European settings.
So maybe I have to take the next questions because Patrick is offline again. Do you have information on how effective the smartphone apps are in reducing spread?
Well, there's two aspects of effectiveness. So the technology, I mean, a friend of mine, Christoph Fraser, who's based in Oxford, has done a lot of the work on this. there are two aspects of effectiveness. And one is just basically coverage. So they work on the basis of, you know, two people having the app on their smartphone and then using Bluetooth, the proximity, the interaction between those two people being monitored. So even assuming the algorithm being used to detect proximity is accurate, you can immediately judge from just the way they work that effectiveness in reducing transmission is going to go as the square of coverage. You need two people, both people, to be using the app. So for instance, if 25% of the population are using the app, then only about 12% of interactions between people are going to be monitored. And that's going to limit effectiveness. If, on the other hand, 75% of the population are using the app, then we should capture, you know, 50% of interactions or more, and you could have a much bigger impact. The second aspect of effectiveness is what people do with the information provided, and do they actually isolate if you tell them to? And that's more of a behavioral science question.
Okay, and we have a question from Wiles, I guess Andrew. So the question, if politicians can only implement hard measures like a lockdown, if in addition to the scientific prediction, there are also facts like outgoing death rates.
Yes, and I think that's been true across Europe, unfortunately. I mean, I think in many cases, the senior politicians, Macron in France, I've heard, and certainly Boris Johnson in the UK, from what I've been told, were well aware of the need to implement more measures, but just felt they didn't have enough support from their political constituencies to do so until really, as a friend of mine put it, they were looking down the barrel of a gun, that they could actually point to certain hospitals filling up, and it was kind of more. And even then, they've been the decisions of both countries to lock down. There have been plenty of people in the media who've been opposing those decisions.
Then we have a next question by Vincent Fabre about the importance of super spreaders, individuals or events.
So, I mean, it's a mixture of individuals and context. So when I said there's heterogeneity in infection, which is often called super spreading, it's absolutely true. There have been some notable examples of one person infecting dozens of others. I don't think that has been a key driver of overall transmission. For one thing, just because for much of this pandemic, such mass gatherings have been prevented. But I do think it's been important for at a lower level. So first of all, at the moment, most transmission is happening in households, and that's not really super spreading. I mean, that there's about somewhere between a 30 and 50% secondary attack rate in households. So it's not that there's some large portion of people who are not infectious at all, but there is biological variation in infectiousness. But layered onto that, outside the household setting, there appears to be a lot more variability. And it's difficult to disentangle whether that's mostly driven by just personal variation in contact rates or personal variation in infectiousness. I mean, there's a lot more needs to be done on it, but it is very significant outside the household.
Then Sebastian Werten is asking if there is a statistics on reinfection of recovered persons.
There's getting more data on that. I was on a government call this morning which reviewed the data in the UK. So if you look at, there's been a number of published studies, but if you look at seronegative people, you look for evidence just based on serology. Some people, you survey after the first wave a bunch of people for antibodies. You have some are seropositive, some are seronegative, and then you look in the second wave for what proportion of each group became infected. Then you would conclude crudely that being seropositive gives you about 80% protection, 80 to 90% protection against reinfection. So reinfection is occurring, but at a much lower rate than the risk if you've never had it before. If you look based on people who tested positive to the virus through PCR in the first wave compared with the second wave, And there's very few studies of this, but there's some. It looks like the level of protection is much higher, well over 90%. So if you've had a positive PCR test for the virus, then your chance of getting infected in later months is at least 90% less than somebody who hasn't. That probably reflects the difference between that and serology, probably reflects the fact that anybody who tests PCR positive likely has a very great majority of them have a very strong antibody response. But there are some people who get infected, never test positive for PCR and get a lower antibody response.
There's a question in the same direction by Tim Seaman, which is basically, it's the antibody level, it's seropositive, it's not a binary 0-1, but it is continuous. And is there a correlation with the probability of reinfection or seriousness? I
agree, it's a good question, one we can't really answer. I mean, we would expect from other respiratory viruses and other coronaviruses that that pre-existing immunity from past infections would modify disease severity, and we don't have any firm data on that as yet.
And we have an anonymous question about is there really a movement towards well-established epidemic forecasts which can guide government decisions, and how well will this be accepted in the medium to long term?
Yeah, so I think there's two different types of kind of epidemic modeling, which could be maybe not called forecasting, but is future looking. One is the sort we did back in March, I mean, our report 9, which is really scenario modeling. We didn't have enough data to make detailed predictions at the time, but it asks the question, given what we know about a virus, what's the potential range of scenarios we could see, and how are those influenced by different policy choices? And then there is detailed forecasting, or making projections. I mean, projections is the word I prefer, because generally what we do is we say, we fit models up to the current time, and then we say, if everything stays the same, what's likely to happen in the next few weeks? Those can be much more reliable. They're really short to medium term forecasts, and they are useful, and the US has done a lot of this as well. There's a different goal to that sort of modeling, though. I mean, that really is just saying what's the likely immediate term trajectory of the epidemic. You can use a simple statistical model to do that. You don't need a complicated transmission dynamic model. But it informs policy making, because for instance, if you're predicting exponential growth and healthcare systems being overwhelmed in 2 months' time, then that does inform policy. But it's not quite the same as trying to actually use a mathematical model to model different policy options.
Then a question by Tim Hyde for backtracing the introduction of COVID into Europe, and if it's understood why Northern Italy was particularly affected, or if there's some theory that it actually originated there and then China.
Yeah, so I mean, I think the data is overwhelming. Really, genomic data is overwhelming that it originated in China. I'd say epidemiological data is difficult to use for this because, I mean, testing was only started at a certain time point and took time to ramp up. So all the early trajectories of the epidemic in European countries are biased by the scaling up of testing. So really, it's the genomic data which provides the best evidence. And I mean, I'm not completely on top of it. My understanding is that the most recent common ancestor of current clades of the virus circulating in Europe has a kind of origin date of somewhere between January and February. I mean, so it's, in my view, it's quite unlikely that we saw any COVID infections in Europe in 2019.
And how big is your group actually, who has produced so much data?
Oh, yeah. So the center overall is well over 100 of us, but I mean, there've been in the peak week. We haven't all been working on COVID. I mean, the peak week, I would say we had probably 75 people. I mean, I should say it's not just a personal, I mean, academic group, and it's more like a university department. I mean, we have multiple full professors, academic staff, and we basically all pull together around a common research agenda. So, but yes, over 70 people in the peak week, and we still have something like 25, 30 people working on COVID now.
Question by Dina Carbone. Could this data from Manaus, where you had basically a full infection of the population, be exploited to refine the estimate of mortality?
We have looked, I mean, so I'm not complete, it's a colleague of mine, Nuno Faria, who's Brazilian himself, who's done a lot of that work and working with Brazilian collaborators. I mean, I think they have looked at infection fatality ratios in that population. I think it was, I mean, of the order of, at a population level, of the order of 0.3, 0.4% from memory, but I may be misremembering there, or maybe actually 0.25 to 0.3%, but it's a very young population. I mean, so it's a kind of frontier population in the Amazon. It's mostly, you know, people working in the logging community, on large farms and the like. So it's a very young population, more like a low-income country. Also, what we know is that mortality, I mean, was not accurately recorded. I mean, lots of deaths were probably missed. I mean, there were mass burials going on, and not all the mortality was counted. So, in fact, it's in those sort of contexts, it's quite difficult to really use that data to get definitive estimates of mortality. It's rather better in high-income countries with much more rigorous testing and death registration, and to get a handle on infection fatality ratios.
I have myself a question about young populations. It would be interesting to exploit boarding schools to reduce the transmission rate among children. Has this been done?
I'd like to ask one question concerning.
I think you cut out.
I think you are broken again. Type it and I will ask it.
Well, turn off your video, Patrick. Carry on, Uli.
Yeah, maybe you can hear me now.
Yeah.
Can you hear me now?
I can just about, yes.
Not so well. Because of the intrinsically exponential nature of pandemic growth, uncertainties on the input data grow up in very large error bars for the predictions. And we've seen that the data are rather scattered. Is there any effort of governments and agencies to structure data in a manner that will be more amenable for accurate modeling?
I think it's about, I'm not sure about structuring data. There's not much one can do about exponential growth, and therefore the fact that you're trying to estimate, yes, that the errors grow exponentially. I mean, that small uncertainty in growth rate can lead to very large uncertainty later on. I think fundamentally, clearly just more data helps. And pulling together different data streams, different types of data, as well as just case data, data on hospitalizations, serology, all the data streams I talked about, allows you to test the consistency of patterns you see in one data stream against the ones you expect in others. But I'm not sure if there's any magic, silver bullet which can prevent the challenges of exponential growth affecting estimates.
Thank you very much.
And
so you
had a second question about the boarding schools. So can one exploit this to get better data about transmission among children? Is there any specific statistics?
I mean, boarding schools in influenza epidemics have told us a lot about transmission in boarding schools. They're very specific settings. So I would say, I mean, you can get interesting scientific insight into patterns of transmission. It's not very generalizable to other settings because boarding schools are both households and schools. Undoubtedly, some of the, data collected by Institut Pasteur on back in the first wave, I can't remember the name of the region, but on transmission in community settings, but around both primary schools and secondary schools, provided very useful data, and that study showed something which we now know to be true from much more data, which is that certainly older teenagers seem to transmit just as well as adults do. And we've seen that across Europe, but certainly in the UK as well, when schools, one of the contributors to the second wave, the autumn wave of transmission, was definitely high schools and universities reopening.
Okay.
Thank you very much, Neil. Oh, maybe, unfortunately, Neil informed us that he has other commitments.
Yes,
and
I will answer now. Question.
Okay, so we take that last question. Okay.
Okay, so Hartmut answers if there is any understanding why in European countries like France was much more affected than, for example, Germany. Is it the initial spread of infections or cultural differences?
You're saying, was the question, why did Germany have a kind of much better?
Yes.
So I think, I'm not sure about cultural differences. I think Germany, I mean, the big thing about Germany is they implemented larger scale community testing at a much earlier stage. And so they had and it may be partly the devolved nature of health response, more testing capacity. They faced the same challenges as France and the UK in terms of imported infections, but they implemented more effective contact tracing and local measures before the national lockdown started. Local social distancing measures and school closures and telling people to stay home in hotspot areas. This is way back in February and then early March, than did any other European country. And so they kept infection numbers lower. And then when they lockdown had a very similar effect in Germany as to what it had in France and the UK, but they locked down from a state of having fewer infections. Also, I mean, they almost certainly, from the data we've seen, got slightly fewer infections imported into those countries than did, into Germany, than did Italy, France and Spain and the UK, for reasons we're not completely clear on.
Okay, thank you. So
Thank you. Thank you very much. It was a pleasure. Bye-bye.
Thank you.
Thank you very much. Attendees. It was a real pleasure to have you here. I apologize for all the trouble in the discussion due to my connection problems. I hope went well. Thanks from ILL. And we invite everyone to join us in January for a colloquium on X-ray free electron laser by Sakura Pascarelli. Thank you. Goodbye.
Bye.